Cystic disease of the kidney. Basically, they are the ciliopathies. Ciliopathy means the microtubule 9 with central structure. Cilium from the surface of a cell. It is present in all the cells of the human body. So when they're diseased, affected, you do have some of the impact on the ultimately on the kidney cells, kidney tubules, and the glomerulus. So you get the cystic kidney disease. So there are genetics. By far the commonest pediatric cystic disease is the ARPKD, autosomal recessive polycystic kidney disease. Number two, the adult onset disease like ADPKD is also possible. Even neonatal possible incidence in 2% of cases. And third one maybe nephrophthalmophthisis and ADTKD. Previously used to call it MCDK, autosomal dominant tubular interstitial disease. Previously we called it multicystic kidney dysplasia. And finally few more uncommon diseases and some non-genetic disease like your obstructive dysplasia, multicystic kidney dysplasia, and acquired simple cyst, and then complex cyst, tumor with cyst, hemolytic uremic syndrome. They can also have cyst. Hypokalemia for a long time can also have some cyst, and a person on maintenance hemodialysis can have cyst. In virtually, when someone is in maintenance dialysis for 10 years or more, almost 100% of these patients do have some cyst. So, predisposing events in the cyst formation in children are, the ACE inhibitor used in the mother, IUGR in the mother, and your mother with the vitamin A deficiency. So, ARPKD, autosomal recessive polycystic kidney disease, is by far the commonest. So, what is this actually? This is the autosomal recessive polycystic kidney disease is due to the mutations of the PKHD1 gene, and at times your DAG1PAL and few more uncommon genes are may be involved. And what this gene product is fibrocystine or fibrodactin. This gene product causes the tubular cells and to become weak, and they turn your we call it the dilated and ectatic, and ultimately take the shape of the form cystic form. So in severe cases, you do have neonatal presentation, early infancy presentation, and childhood presentation. Both three are possible, and ultimately they cause the renal damage. Infection is there, stone formation is there. These children they do develop hypertension, and they have tubulopathy features like polyuria, polydipsia, and your growth failure, and hyponatremia, hypokalemia, and also your hypocalcemia, at times hypomagnesemia. So in severe cases, they do have the less urine production, oligonuria, and in the early infancy, in the womb, in the intrauterine life, what they have, they do not produce in the urine. The mother has less amniotic fluid, maybe zero even. So ultimately, when the newborn is growing in the womb without fluid, what will happen? He or she will be compressed in the uterus, giving rise to the Potter sequence, and 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 non-development of the lung, hypoplastic lung, so thereby distress, respiratory distress soon after birth, and ultimately when the child is grown up, the hepatic ducts, they also have some of the ciliopathies that do have your ductal dilatation. When as ductal dilatation is associated with the congenital hepatic fibrosis, you do have your Caroli syndrome, and so the presentation is wide diverse from neonatal period to the extreme, and good amount of them they need ultimately renal replacement therapy or kidneys replacement therapy, whatever you call it, and then and other symptomatic managements like infection control, hypertension control, and ultimately they need transplantation. So when you go for transplantation, because of the bigger size by the dilated system of the tubule and glomerulus, you do have more space occupied in the abdomen. Thereby, you have a little bit of space difficulty when you go for transplantation. And those cases, you need to excise one kidney to put the other kidney into the tummy. Autosomal dominant polycystic kidney disease can have neonatal or early infancy or childhood onset, less small amount of cases, but good amount of time they do have presentation in the fourth and third decade of the life, and they develop the ESRD by sixth or seventh decade, same presentation, but they can have the pancreatic cyst, brain cyst, tooth hemorrhage, and your coronary and aortic aneurysm is possible. Your MBB, mitral valve prolapse is possible. Abdominal hernia is possible in those cases, and your basically this child can present with initially starts with one cyst. So simple cyst can be a beginning of the autosomal dominant polycystic kidney disease. Third one is the nephrophthisis, cystic disease commonest. Because of the defect of the nephrophthisis 1 to 15, your gene NPHS 1 to 15, and few more other genes are there. In 30% cases, we do not know what are the genes. They have autosomal recessive inheritance, and its presentation is less than 5 years, and more than 5 years, so 3, 2, 3, 8 respectively. And above 5 years, you have NPHS1 predominantly. These children can be bedwetting sort of presentation. They have tubulopathy. Ultimately, means polydipsia, growth failure, and concentration defect. And finally, these children develop CKD in the how much, say 8 to 10 years or so. And treatment is same as autosomal recessive and dominant PKD. Few more other diseases, cystic diseases, are not that uncommon. As I said earlier, the glomerulocystic disease, your Wilms tumor, cystic nephroma, and the lymphangiomas, and some of the carcinomas do have cyst formation. So take these things in seriously, and the exclusion of these tumors, they are malignant tumor, of course, should be taken into consideration. And RAN gene REN have aldosterone deficiency, mutation. So and then they can have normalized cyst when they is being treated. So they are treatment responsive. And then for Kakut hypodysplasia, they can also bar the reflux, your uteropelvic junction obstruction. They also can have cystic formation. So syndromic association of the cyst is quite common. Your Down syndrome, nail patella, Meckel-Gruber, the Beckwith-Waddleman, tubular degenesis syndrome, columnar iris, and then few more brachioautorenal, and they have also cystic kidney disease apart from their cystic other wide range of presentations. And treatment of those cases is again KRT, kidney replacement therapy, hypertension control, and other symptomatic supportive care of the CKD.